Hi everybody, I'm Kate Wakelin. I'm from the Unicorn Foundation. I know I've spoken to quite a lot of you on the phone or via email, so it's been really great just wandering around outside and putting some faces to names. And I know several of you have driven a long way to come tonight, so I really do appreciate you taking the time and the effort to come here this evening. And this is the general disclaimer that you get at the start of things like this, so the information that we'll be talking about tonight will be general in nature. And it can be really tempting when you come along to something like this, especially if you know the doctor or the person who's presenting. It's really tempting sometimes to ask questions about your own situation. We'll try and keep it as general as we can. We've got a fairly good period of time where we'll be able to grill our guest experts tonight and ask them lots of sticky and tricky questions. So I'm going to invite you to do that when the time comes. If you ask a question that I deem to be a little bit too much just about an individual situation, I may paraphrase that and broaden it out so that it's relevant to the other people in the room. So just to let you know that that's what I'll be aiming to do, so that we all can relate to the answers. And so I think without further ado, I'm going to get up and talk a little bit more about Unicorn Foundation and support services at the end, but I'm going to introduce our first speaker, who's Dr. David Ransom, and I'm going to tell you a little bit about him. He probably doesn't need a great deal of introduction because most of you will know him, but David's a medical oncologist with 25 years experience as a clinician.
Roughly.
So he graduated when he was 10. Previously, who worked in both public and in private practice, but more recently he's just been in the public system. And he's currently with Fiona Stanley, where we are. He's got a number, so his focus is generally on gastrointestinal and neuroendocrine cancers, and he's got a number of publications in this area. So for the past few years, David's also been working as the Principal Medical Advisor in the WA Cancer and Palliative Care in Western Australian Department of Health, which involves policy and planning for cancer management at a state level. So that's pretty impressive. I'm looking forward to hearing about that, maybe. He has a particular interest in equity of access and safety and quality of cancer treatment. And I love hearing that about our clinicians, that's actually a passion, allowing equitable access and making sure that you as patients have the best chance of getting the best treatment that we can possibly get. So thank you so much for coming, David. I'm really very thrilled to have you along, and I'm going to move my little microphone on to David's lapel, so bear with us for a second.
Welcome everybody. So tonight, I think the title of my talk is Medical Oncology Update, and then I was all set to do a medical oncology update, and then Kate said, I want you to talk about some other stuff. So I'll get a little bit, there's not a hell of a lot new since I last spoke, but I will touch on what the current state of medical oncology is towards the end of my talk. The first thing I was asked to do was to give a bit of an overview of what NET tumours are. And so I'm just going to talk a little bit about what they are, and it's not an easy question to answer. So this is the definition. Neuroendocrine tumours, NETs, are neoplasms, they're growths, that arise from cells of either the endocrine, that's hormonal cells, or the nervous system. They most commonly occur in the intestine, and that they're also found in pretty well any organ, but particularly intestine, pancreas and lung is where they occur. They have a range of aggressiveness, and they keep changing their names. Now this slide is probably not a slide for the audience that I have today, but this is just, the WHO stands for World Health Organization, and the World Health Organization often provides international guidelines for how we should classify tumours. And as you can see, roughly, well, there was a statement in 1980, another one in 2000, another one in 2010, and another one in 2017. So how these tumours are classified keeps changing, and over the last 10, 14 years, they've changed the system every 6 to 7 years. So that makes it a little bit, it's not so easy even for the docs to keep it up to make sure that they're using the correct nomenclature. But for people who are lay people who are not particularly in it all the time, it gets really confusing. So when I was a medical student, which unfortunately is a long time ago, they were called carcinoid tumours. And as you saw from the previous slide, they're still commonly called that. That's what, generally speaking, when you come along to these talks, that's what we're talking about. We're talking about low-grade neuroendocrine tumours, and they have a very indolent natural history. You can live with these tumours in lots of spots. You can live with it for a long time. But there are, at the other end of the spectrum, there's what these things called high-grade neuroendocrine tumours, and they are extremely aggressive tumours, are a very aggressive cancer and have a usually very rapid course of their illness, and sometimes you can cure them with chemotherapy, but unfortunately that doesn't happen very often. So this is the so there are here which are NETs, which are low-grade tumours, which are well-differentiated tumours, and there are NECs, which stand for neuroendocrine carcinoma, and they're the high-grade ones. And this is how we classify them. Again, it's probably too much detail for the audience, but just to say, I want to reiterate again, we do all this stuff and we try and work out if it's a low-grade tumour or a high-grade tumour, or is it somewhere in between. We then have the problem of, well, we're dealing with a biopsy, which is a 0.5% sample of the whole tumour, and is this sample representative? And we go through all this stuff, and then we look at the cancers and see how rapidly they're progressing on CT, and then we come up with have a bit of a guesstimate as to whether it's high grade, intermediate grade, or low grade. And this is how the World Health Classification classifies pancreatic neuroendocrine tumours. But the bottom line is, what I was trying to get across to you is that there's a spectrum of disorders encompassed in neuroendocrine tumours. The vast majority of what we talk about today and what Unicorn tends to focus on is the low-grade end of the spectrum. But I understand that there's a few people in the audience that have not been here before, and they're wondering what we were talking about, and there's that high-grade end of the spectrum as well. I was asked to talk about epidemiology. So this data is courtesy of the WA Cancer Registry. Cancer in all states in Australia is a notifiable disease, and WA Cancer Registry estimates they capture virtually more than 99% of cancers in Western Australia. It's a fantastic resource. So this is the data for low-grade tumours. I've excluded high-grade. So this is incidence 1982 to 2015. So we've got more than 20 years of data here. And if you look at this plot here to start off with, you can see that the vast majority of low-grade neuroendocrine tumours occur in the appendix. And often patients come in, they have appendicitis, they have an appendicectomy, and then the pathologist looks at the appendix and says, there's a low-grade neuroendocrine tumour in the appendix. And that is, I think it's about 1 to 2% of appendicectomies. If the tumour is small, and that is less than 1 centimetre, those patients are virtually always cured, and they have a very good prognosis. And then, so that's by far the most common type, and then the next most common site is the rectum, small intestine, terminal ileum, and then lung. If you include lung, they've split up lung into lower lobe, upper lobe, and lung not otherwise specified. And if you probably added those up, the bar should be bigger, because really they should have been added together. And then after that it's pancreas. And they've split pancreas up too, in the head, tail, pancreas not otherwise specified as NOS. So really those bars should be a bit bigger as well. But that gives you an idea of where the common sites of the diseases are. How are they classified? The pathologists are still using the old term carcinoid tumour, not otherwise specified, neuroendocrine tumour, not otherwise specified, form the majority of what the pathologists reported. And sometimes even the pathologists haven't been using the WHO system. And slightly more males than females. This is total incidence. Again, 1982 to 2015. So the top graph, this is 65 plus is the blue, 18 to 64 is the green, and 0 to 17 is the red. So I suppose the take-home message from that is that it very occasionally occurs in people under the age of 18. And there's no really clear trend, whether it's in older or younger people, the age ranges are staying about the same over a 20-year period. This graph here is what they call a stack graph by incidence. Again, it's just a different way of displaying the age range of the patients. You might look at it and think, wow, what's going here in paediatrics in the 80s and early 90s, because that seems to have gone down. You could, I don't know. But it is a bit odd, isn't it? So obviously the population of Western Australia is increasing, but this is cases per 100,000. So this is adjusted for population. And as in all Western countries in the world, the incidence of NET tumours is increasing. And that's seen in the United States, it's seen in Europe, and Western Australia is also following that trend. So here's the 10-year survival all up. That's lumping everybody together. Everybody with a low-grade neuroendocrine tumour. Here is the survival curves. And obviously we're doing better. These are the 10-year survival 1990 to 1999. This is the 10-year survival for the 2000 to 2009 cohort. You can say, how can we have 10-year survivals on patients who were diagnosed in 2009? You can do some statistical analysis and do a thing called a Kaplan-Meier curve, and that will predict, as long as you've got a reasonable amount of data, it will predict the recurrence. So we are doing better. Patients are living longer, comparing the decades. So this is survival by anatomic site. I only got the data out for 5 years. I think for low-grade neuroendocrine tumours, 5-year data is a little bit premature. You probably need the 10-year data to get a really good feel for what's going on. But as I stated in early up, carcinoid tumours or low-grade neuroendocrine tumours of the appendix generally do very well. And I don't, you know, there may have been, this curve almost sits at 100% all the way across out to 5 years. The small intestine ones don't do as well. So that's the epidemiology bit of my talk. So I suppose just in summary, like in all Western countries, the incidence of NET tumours is going up. Generally patients, particularly if you have an appendix, do very well. Treatments are getting better, people are living longer. You can see that from the 10-year cohort data. And the prognosis does vary a bit depending on the site of the tumour. Some sites do better than others. So the next thing Kate asked me to talk about was immunotherapy. Immunotherapy is a new type of cancer treatment that's really come along in the last 4 or 5 years. 10 years ago we thought that it didn't have anything much to do with cancer, but now it's, for some cancers anyway, it's markedly changed the treatment landscape. And that's particularly for melanoma, particularly for renal cell carcinoma and lung cancer. Not so great in NETs, and I'll show you some data in a minute. But Kate asked me to talk about immunotherapy because it's a new treatment, so we haven't exactly worked out how good it is or how bad it is for NET tumours, but this is basically how so this is immunotherapy in 4 slides. If you have a bacteria or a virus, the body instantly recognises it as foreign and it needs to be got rid of. The problem with cancer is that it arises from your own cells. So it's sometimes hard for the body to recognise that this cell shouldn't be there. But it happens sometimes in cancer that the cancer cells become immunogenic or can be recognised as foreign by the immune system. And how this all worked was only really worked out about 10, 15 years ago. So this is a thing called a dendritic cell. Dendritic cells are responsible for presenting the abnormal things to the T cells. The T cells are the cells that do stuff. They kill cancer cells, they kill viruses, and T cells kill bacteria. But you've got to have a bit of a damp on your immune system, otherwise in some diseases your immune system can get over-revved up and attack normal tissue. So there has to be a balance between your immune system recognising abnormal things and also recognising self. So in cancer, to get what we call an activated, this is a T cell which is suppressed, and it needs 2 signals to activate. So this is an activated T cell over here. If you have this one and this one, CTLA4 suppressing this suppresses the T cell. However, if you interrupt this one here, this time with a drug called ipilimumab, then these 2 signals become activated, and you get an activated T cell. An activated T cell can go around and recognise cancer, and if given the right circumstances, it will destroy that cancer cell. So often cancer cells have developed a way of escaping the immune surveillance, and you can interrupt it in this instance with a drug called ipilimumab. The other way that it's done is that there's a thing called a programmed death receptor. All cells have a programmed death receptor, and you can interrupt these two signals here, suppress the immune, this T cell. You can come along with an antibody, bind it on to the programmed death receptor 1, which interrupts this signal. The T cell becomes activated, and the T cell goes along and eliminates the cancer cell. So that works really well in renal cell carcinoma, it works really well in melanoma, works in a proportion of lung cancers, but not so great in NET tumours. And then there's the fourth type of immune therapy, which is where you actually alter the T cells. So what you do is you harvest a whole lot of T cells, then you insert a gene into the T cell, which makes the T cell recognise the cancer cell. Then you grow up millions of these cells, and then you infuse them back in, and then these cells go around in the body, recognise the cancer cells and knock it off. That's pretty new. It's being done a little bit in haematology, but it's a little way off from what we would regard as standard therapy, but it is on the drawing board. So there's not much data in NETs. But this is about the only, but there are a number of trials going on. And this is a report of pembrolizumab, which is PDL1, programmed death ligand 1 inhibitor in NET tumours and carcinoids. They still call them carcinoids. So they took a whole bunch of patients and they did a biopsy of the tumour, and you had to have some positivity for PDL1, which was set at 1%, which wasn't very high. So of 276 patients that were screened with tumour samples, they found 36% had some PDL1 in them, so 2/3 were not eligible for the study. So in the patients that they screened a whole lot of cancers, just NETs, but in this group there were 16 patients with PNETs and 25 had carcinoid tumours, some lung, some GI, and 9 were classed as others. Median age of the patients was early 60s, and most of the patients had quite a bit of treatment prior. Median follow-up was 20 months. The primary response rate, that means tumour getting smaller on CT scan. So 1 patient with PNET got it, and 3 patients with carcinoid got tumour shrink, so that's 6 and 12%. So not really what you would call fantastic, because that's what they were looking for. Among the responding patients, like a lot of things, the duration of response was reasonably long, at around 9 months. Not super long, but you know. So, not super enthusiastic about pembrolizumab in NET tumours. It doesn't seem to be fantastic, you know. There are some other studies going on, but the results are not available so far. People often ask about what's new, and they hear about, you know, that guy, the footballer, Roughhead, can't remember his Christian name. Jared Ruffett, you know, apparently he had lung metastasis. He had melanoma in his lungs, and he got immune therapy, and it's all gone away, and he's back playing footy. But he's got melanoma, and that's different. But there are these sorts of stories on the news, and I think, understandably, it's a bit hard to differentiate between different cancers. But it's just so people often ask, and particularly as the treatment is new, there's not a lot of long-term data around, so we're working in a bit of a data-free space, but certainly the initial results are not great. So what do we have now? So the current systemic therapies, so in other words, what we've had, if you've got a localised tumour, you have surgery, and that's been around for a long time. Radiotherapy is also sometimes used in low-grade neuroendocrine tumours, but it's not a particularly radiosensitive tumour. But if you've got a tumour all over the place, or in a number of sites, what have you got? You've got hormone therapy, and that is lanreotide or octreotide. Either one of those molecules is fine. We have peptide receptor radiotherapy. That's where you take a lutetium molecule, put it on an octreotide molecule, and then put it in, and then the octreotide molecule goes around, finds the octreotide receptors, which are predominantly on the cancer cell, and then it gets a lot of radiation. For pancreatic nets, sunitinib and everolimus are available. We have SIRT, that's selective internal radiotherapy, for patients who have a lot of liver disease and not much else. It's a way of giving high-dose radiotherapy to the liver. And we have chemotherapy with capecitabine and temozolomide, and possibly streptozotocin, though we haven't used much of that drug. So they're all easily available now at virtually minimal cost. Emerging treatments, there's some data that a drug called everolimus is useful in patients not only with NET tumours but also with other low-grade neuroendocrine tumours, and that is available. Cabozantinib is a drug which is got a very good track record in renal cell carcinoma. There's a US study that's about to start looking at cabozantinib. It looks like it's a pretty good drug. It's an oral thing. I've tried to see if they were interested in coming to Australia, but they thought that they'd get enough patients on their study just in the US. There's another drug called pazopanib. Again, that's shown some activity, not so easy to get hold of and quite a high cost. And there's a chemotherapy called Folfox, which is a standard chemotherapy that may have some activity, which is easily available. To finish off, there's an update on the clinical trials. Some of you may have heard about control nets. Control nets is a randomised study that we're running in Australia. It's various combinations of peptide receptor radiotherapy and chemo. We've nearly finished the study. We're aiming to get 74 patients on, and I think we're at number 70 or 71. So that study will finish to new patients very soon. We anticipate getting some results in a couple of years, because it'll take that long to get the follow-up. New trials that are coming along here at Fiona Stanley. We have a COMPETE study. So one control nets finishes, we're going to hopefully open COMPETE fairly soon, and that will be peptide receptor radiotherapy versus everolimus. And I think where there's going to be 4 centres in Australia with that study open, and we should open that later this year. Defining Nets is a quality of life study run out of Peter McCallum. We're going to be opening that study later this year. There's the pituitary long-term toxicity study. So if you have peptide receptor radiotherapy, your pituitary gets a very high dose of radiation. And the question being asked is, if you've had peptide receptor radiotherapy, what is your pituitary function more than 5 years down the track? That study will open, the initial run through is nothing much happens. You know, your pituitary's okay, but there hasn't been formally studied, and we're going to be one of 8 centres in Australia and New Zealand that run that study. And then there's another study run out of Peter McCallum called Net Sanguis, looking at circulating cancer cells as a predictor of how things are going. And then finally there's the Planets database. So Ipsen very generously, it's the company that makes lanreotide, has provided funding for an Australia-wide database. So we're aiming to get most patients with NET tumours on an Australia-wide database and recording quite a few variables about tumour location, grade, symptoms, a whole lot of stuff. And if we can get a big patient database, we can then interrogate it for questions that will hopefully drive clinical trials and help refine treatment. I think that's a pretty technical talk. And but anyway, hopefully I didn't lose you along the way too much.
Thank you so much, David. I'm going to stand close to you so that the
okay.
can...
I'll stand to this
maybe
side.
We'll swap places.
There
We've got a few minutes to grill David now because he's finished early.
Okay.
So thank you, David. So I'm just wondering, we'll certainly have David and Dr. McDonald and James, our psychologist, up to answer questions during the panel discussion, but has anyone got anything burning they would like to ask while it's fresh in your mind?
Only 4 minutes early.
You've done well. You've done well.
That's not too bad.
There's one up the back.
Yeah.
Oh, and then so.
Yeah.
Sorry, you
Yeah.
can go first.
Let's go with you, and we'll.
Do you think it's down to better diagnostics, the increase in...
Yeah. So yeah.
So the question is,
yes.
do we think it's?
Is it?
Diagnostics, or do you think it's any other any particular sort of reasons that are jumping out to you through your own experiences?
So the question is,
Yeah.
is the improvement in the stats?
Increase in incidence.
The increase in increase in
incidence
because
just
we're picking
is it
more up?
real, or is it just some artefact because we're diagnosing it better?
Yeah, diagnostics have improved.
Yeah.
Is that $1 million question?
Well, yeah. I think we're getting better at diagnosing. No, sorry. I think there's a genuine increase in incidence.
Yeah.
You know, we've had body CT scans have really been available since about 1985. Now, the CT scans that we have now are better than what the 1985 ones, but neuroendocrine tumours do look different to regular cancers on CT scan. And I think that, I don't think it's diagnostic tests that's improving our yield. I think there is a genuine increase in NET tumours. That's my gut feeling. What do you think, Bill? As an imaging person.
I think it's probably a mixture of a real increase in incidence, but also particularly for little tumours in the stomach and small bowel. A lot of people have endoscopies now where they swallow the black snake, and people are finding these little tumours that previously might have gone undetected and possibly would have never done people any harm. So there is, I think, a mixture of increased counting, but also a real increase in the occurrence of these things.
So that, of course, begs the question of what lifestyle things are we doing different, because the genetic pool's the same. So what are we doing that's causing the increased incidence in these things? And
I was talking to a couple of ladies out the front, and they were saying they're all within a really small geographical radius in a very small country town with only about 1,500 people, and there's 3 of them that they know.
hard to
Theories?
know. I don't know. Cancer Registry keeps data on postcode. And I don't think anything jumps out from the postcode data. There doesn't seem to be clusters in particular suburbs.
So there's a question. Oh,
And also,
three in a row.
It's hard to.
The thing is, that raises another one. The postcode. Okay, hands up. I'm one of those three ladies. We all moved.
I wasn't gonna call you out.
We didn't spend our lives in that area. Postcode wouldn't come up.
Yeah.
So
Yeah.
what you're saying is you grew up earlier in life in that postcode, but you've all moved since then. So
Yeah.
the registry won't capture that.
Yes, that's true.
All over Australia, so.
Yes. Yeah, and it won't capture that data.
There's so much to know, isn't there? There's so much
Yeah.
more to learn. Was that your question?
My question was about the increase,
Yeah.
on, why. What about familial, genetic reasons? Does
Well,
that
a small
matter?
proportion of patients do have these tumours on a familial basis. And
Do you have a percentage, David?
off the top of my head,
Sorry, put you on the spot. It's my job.
I don't know, I would have thought 10 off the top of my head. So 9 out of 10 patients, it's just bad luck. But a proportion of patients, it is on a familial basis.
Well, look, thank you so much. Before you run away, I'm going to grab that microphone.
Right.
And hope you'll join us in thanking David, and we'll welcome Philip to the stage.